longevity as well. So the one point of interest that comes out for us, and I'll just mention this one, I won't go into too much detail on this, but we have noted that the training intensity, in other words, the harder the training is with regards to the intensity, not the duration and how far they run for, but the intensity of the work, then injuries go down. Whereas if the training intensity is low and they're doing more plodding type of work, then the injuries go up. So you might think, well, the harder they work, surely that's going to be more injuries, but it's the other way around. When we had a chap called Scolari, his Portuguese manager, his particular coach, fitness coach, did very straight line running work, which is quite popular many years ago, and our injury rates soared in about September, particularly muscles, like it never happened before. Whereas this coach, as well as one we had called Marino, high intensity work, very much that the injuries are reduced. So I'm a firm believer that it is the coaches that cause the injuries, but you have to be careful who you say that to. Last thing on this is that with these accelerometers, you can measure the difference on what happens when the left foot hits the floor compared to the right. So again, for us, and the end stage of rehabilitation, we had a player recently, this player who had a chondral defect on the lateral femoral condyle, and you could see that he was decelerating without the same speed. Let me rephrase it. His ability to decelerate on the affected leg was poor compared to the unaffected leg. So not ready to go back. Maybe susceptible to an ACL injury, for example, because landing on that leg, he guards it. He decelerates with his right leg, he doesn't decelerate as well with his left. So end stage of rehabilitation, you're wanting the 47s and 53 comparisons to become more 48 and 50s, so they are the same one side compared to the other. All about injury prevention. This was just to finish with a few little cases that it's always interesting for me how much imaging helps us and how much sometimes it can harm us. This was one of our forwards who developed a little bit of a tweak at the front of his thigh. We're always worried about rectus femoris injuries because they're a bit of a nightmare for us. We find the muscle hides, doesn't give us information, and then it can tear and recur. So we sent him on for MRI, shows him a bit of edema there within the muscle without going into more technical detail. So you could look at that and think, oh, well, he's got a grade 1, grade 2 injury. Just going about the grading of muscle injuries because, again, grade 1 and 2, 3 for us means nothing. Grade 1 being, what, a millimetre or 0, grade 3 being a total rupture, so grade 2 is what, the other 99%. For me, it's meaningless, whereas if we're given a 3D representation of the size with regards to the 3 planes and what percentage of that muscle is damaged, that is maybe a little bit more helpful. May not change what we do, however, the European audit looking into this 3-dimensional analysis now of the tear of the muscle and how quickly those tend to respond, as they have approximately 1,500 hamstring injuries and increasing, will maybe get us to the point where the size of the muscle is not size of the injury is not a predictive factor, whereas it could be. So anyway, there you think he might be out for 3, maybe out for 4 weeks. Within 24 hours of me telling him what the diagnosis was, his pain had eased and he wanted to train the following day, was adamant he was going to train. So I warned him about the problems with that. Anyway, he played within 48 hours. So there was one where the MRI would suggest we had a little bit of a problem here, yet symptomatically completely normal within 24, 48 hours and played. We've had tears in vastus medialis, 3 centimetre tears in other muscles, a little bit of a discomfort, but completely symptom-free within 1 to 2 days and end up playing in 3 to 4. So we're very much the radiologist working with us, but it's the clinical that takes it a little bit further. That was about rehabilitation of the sound, which I'm sure we need to discuss at this stage. The transverse process fractures in football I mean, that's so useful when the radiologists that I work with can help me, because if the player comes off the table and he is told that he's broken his spine, I've got a lot of work to do to undo that. Whereas if it's a transverse process, and the literature states that if you break 3, it's approximately 3 weeks to get back. If you break 2, approximately 2, and 1, approximately 1. It's nice when they fit into that little box. So this was a fracture transverse process. More often than not, it's a damage to the soft tissues to actually get through there. This was an elbow. The player finished the game, but stiffened up a lot afterwards. But with a damage like that, the radiologist could be great, because he can say, "Oh, I've seen a few of these, no problem. They've had them back sometimes in a week, etc." You've already started that rehabilitation process, rather than you've broken your spine. This is going to be 6 weeks for the bone to fix. That bone doesn't need to fix before they get back and playing. And something like that, we would have them in the water doing some aquatic therapy the day after. In fact, for most of our injuries, we would say get in the water the following day, unless there's a specific reason not to. And the same goes for post-surgery. I put that up just because these CT images that you people are sending me these days are absolutely wonderful. They're probably all old hat to you, but they're like toys to us. And I saw your imaging of the cervical spine. I mean, I think it's absolutely incredible where you can take us and our profession for that. An ankle syndesmosis problem, I put that up. It's just, again, these are particular nightmares for us, and it's a little wee ligament in there, but so much not bothered to an extent on the lateral ligaments. But perhaps, can you just give us 100% confirmation what is going on that anterior and posterior inferior tib fib, because it's so crucial. We can either get them going really quickly, or we've got a problem. We've maybe got an unstable joint. These give us a big problem with a little bit of a bleeding over the iliac crest, but a hip pointer, which it is. A bit of a blood, not too much of a problem, but that's the kind of thing that would keep a player out from our point of view for 3-4 weeks, because of the effect that it has on the abdominal musculature. So again, when I'm giving these stories back to the radiologists that I work with, giving them the feedback, this is how long he took. The next time the radiologist sees it, he might decide to take it a bit further, may decide to scan, or was it a passing comment because the player's a bit pushy. He can say, that's not just a bruise, this is over the top of that crest. You could have a little bit of a problem with that. This was an open kinetic chain injury, so in other words, this player's foot was in the air and he had a kick on the outside of his foot which knocked off his medial malleolus. Don't know if anyone's come across that before. But pre-imaging showed that there were no stress signs in there, but somebody like myself would come back to you saying, could you have a closer look at this imaging? Because we can't believe how somebody can have their foot kicked on the outside of the knock off a medial malleolus without there being pre-existing stress injury, because from a medical legal point of view it's important, but post-injury, if there's any way that you can start to determine for us, yes, this was the case, whereas on this particular case it said there was not a pre-existing stress fracture due to an image that was done 2 weeks before, but I wonder whether you'd be able to give the answers for us for that. And the last one was a player of ours who got a kick in the chest, and actually he got booked for being kicked in the chest. Yes, we were playing Manchester United that day, and he had to go to his homeland very soon afterwards, so we just thought we'll miss the x-ray, could be a bit of a fracture, we'll just go straight for the CT. And just on this particular occasion, these wonderful 3D CD images did not show us a fracture, and the x-ray that was done in Africa did. So technology didn't get us too much further with that one. That, Simon, is all I'm going to leave it. Thank you.
Thank you very much, Brian, for...
So this was just coming through, so the actual answer was this was in increasing incidence, so the hamstring tear was there, and it's the medial collateral ligament.
All right.
Most common cause. Okay.
Thanks, Brian. Yeah. Well, thank you for completing our journey, and thank you for completing yours.
Thanks.
But no, I mean, I think that I wasn't aware, in fact, not being a fan of the round ball, my balls are other shapes, that England were playing France. So in deference to that, I'm very keen that we have an opportunity for questions if anybody has them, but maybe just 2 or 3. If there's any burning questions from the audience. Yes, Mark.
How much radiation does that kind of 3D imaging give to patients?
This is going to be an area of a lot of scrutiny, and it'll be also an area where there'll be a lot of argument between manufacturers, because actually you can imagine it's going to be very complicated to work out. In terms of its benefit, I think that if it's used in a targeted fashion like I spoke to, we don't really need to take, in particular for the extremity work, obviously too much concern out of the amount of radiation from this type of scanning. It's the whole body scanning and the sort of the poly scanning for multiply injured patients that is a real concern. Paul, do you have anything more you want to add to that?
Just it's low.
Yeah. You know,
you're talking in sort of orders of X-ray equivalents rather than hundreds of thousands of X-ray equivalents.
We're talking about, in case you didn't hear that, you know, this particular machine will give about a chest X-ray's worth of dose for one of their investigations, and say if you're looking at the heart. So I think that as long as it's targeted, you know, there's an awful lot in the press at the moment about increasing use of radiation, and the CT manufacturers will pick up on this, and they'll all start making arguments about who's the best and who's got the lowest dose. My point is, in this particular type of focused targeted scanning, the clinical benefits are in a bigger scale of importance compared to concerns about radiation dosage. Does that sort of address your concern? Thank you. Yes, sir.
The coloring of the density of the pictures, is that in any way called pathology or not, or just an aspect of the machine itself?
The three-dimensional movies. Yeah, this is all to do with the workstation. When you put the data into the workstation, you have to set the window levels to sort of strip, if you like, the overlying soft tissue away. And it's really difficult to get it quite right. You never end up with a nice clean bone surface like you'd hope you would get, because you've got sort of soft tissue stuck right next to it. And it really is quite a challenge to get it looking. Yeah, my pelvis looked really moth-eaten, didn't it? I think that was abnormal. But you know, that's just the way in which we'd set the window level. You can play with it for ages to get it right, but there's so much data there, and you're sort of trying to do so many things. So that is an artifact. It's not actually relative. It's not related to pathology or bone density or anything like that. We'll get better at it, I guess, is the answer. You know, these are our earliest attempts. You know, we really need to sort of refine and understand how to make that machine sing and dance and use the workstation properly. Are there any other burning questions? Well, as I see none, I think I'd just like to ask you to once again thank all the speakers for some making Herculean effort to get here, and to yourself. Thank you very much.